All right, so we're going to be talking about chest trauma. So I have not edited these slides, so some of these, like case studies, we're going to ignore. This slide is very important when it talks about the thoracic cavity here, when it's lined by two layers of pleura. They don't define what these two layers are here, but they maybe do later on in the lecture. But those two layers of pleura are the visceral pleura and parietal pleura. The visceral pleura is what lines the stomach, what lines our organs. The parietal pleura is what lines the chest wall and our abdominal wall. And then when we talk about the organs inside the thoracic cavity, obviously we're talking about the left, right lung. We have the heart. We have the esophagus. We have the trachea. We have the blood vessels that are very important. Our inferior vena cava, the aorta. Okay, all those things inside the chest cavity. And here's just another breakdown of it. All right, so when we talk about how we breathe, so when we take a breath, we're not just inhaling through our own free will. What instead we're doing is that we are using a negative pressure system and the air rushes into our lungs because it's a negative pressure system. And then we exhale, we forcefully exhale, causing that air to escape. Okay, now we're going to get into the actual meat and potatoes of this. We're going to talk about the types of injuries. So we have open chest injuries, and we're going to talk about closed as well a little bit later on, but our open chest injuries are caused by penetrating wounds. So when we talk about DCAP BTLS, this is the P, the penetrating injuries. All right. If it's a low velocity weapon like a knife, we typically have a open wound, okay, with no cavitation. But if we have some type of weapon like a gun, then we're probably going to have some level of cavitation. That is, that as the bullet travels through the tissue, it just kind of deforms everything and creates a cavity. And here, obviously, it says if one of the great vessels of the chest is injured, it's going to result in immediate death. We're talking about the inferior vena cava or the aorta. Okay, that's torn. We have a really bad day. Here's just a photo of an individual with an open chest wound. Okay, we can see multiple wounds right here. So a little more medial to the nipple here. We have a wound here, and then we have one that's almost over the sternum. All right, so our open chest injuries, they can involve the heart and any other major blood vessels like we just discussed, and this may include a pneumothorax. Even though it's a open chest wound, we think, what is a pneumothorax? That is an accumulation of air in the chest wall. All that is required for us to create a pneumothorax and that buildup of pressure of air is an occlusive dressing. Just by placing that dressing on there, we're likely to cause a tension pneumothorax that we will have to later on treat. But if we don't do anything, that's going to interfere with that negative pressure system that's required for inhalation exhalation. So it's kind of like a catch-22. We have to treat the injury, but by doing so, we help with their breathing, but we could potentially cause harm later on in the form of a tension pneumothorax. So it's a balancing act. All right, so closed chest injury. So before we had open, that's anything that penetrates the wall of the chest wall. But here we have closed injuries. We get a lot of blunt force trauma. So with these particular types of injuries, we see these in assaults with a bat or some other type of hard object, or in motor vehicle collisions. We see these a lot, especially because they're going to hit directly onto the steering column if they don't have airbags. So that sudden deceleration can cause a shearing of the tissue, the organs, or these vessels that we're talking about here, and they can be damaged just by the act of a sudden deceleration. Thank you very much. Yes. And we're also going to talk about flailed chest and what the definition of a flailed chest is. And we have a very long segment here that's coming up. So a flailed chest segment, you're probably going to get a test question on this about what it is. It is two or more ribs that are next to each other, so they have to be adjacent, that are fractured in two or more places. So two or more ribs that are next to each other or adjacent, fractured in two or more places. And so what happens is that when you have something like this would be a flailed segment or flailed chest, like we would call it. When we breathe in, okay, and our chest expands, instead the segment is going to cave in, it's going to sink in. And then when we exhale, when our lungs return to normal, okay, our diaphragm goes up and our lungs go back to their normal size and position, that segment is going to push out. It's going to bulge. And it's called paradoxical movement that you see here in this slide. Here it's just further explained. And then it just kind of talks about what is happening in the lungs here. So, all right. So with a flailed segment, some do's and don'ts for these people. Don't place them on the injured side, okay? And don't place anything to stabilize that segment, because that's going to restrict chest wall movement, and they're already going to be having difficulty breathing due to the injury itself. And they probably have some type of pulmonary contusion, which we're going to talk about in the following slide. Just the amount of blunt force trauma that it takes to fracture that many ribs is probably also going to bruise the lung and cause internal bleeding into the lung itself. So these patients are probably a good candidate for CPAPs because they're probably going to be tired. When you see them, they're probably just going to be physically exhausted because they're not getting adequate gas exchange. They're not getting adequate ventilations because it hurts to breathe. So they're not going to be taking that good, full, deep breath that they should. Like I was talking about pulmonary contusion. So what is that? Pulmonary meaning the lungs, contusion meaning a bruise. We have some type of bruising on the lungs. And here we may have bleeding that occurs inside the lungs itself. And this can impair the gas exchange. The alveoli can be filled or surrounded by blood, like we see here in this slide. The alveoli is just surrounded by blood, and it impairs that oxygen and gas exchange of carbon dioxide. And I talked about this earlier when we talked about having air inside of the chest cavity. We have a pneumothorax. Pneumo meaning air, thorax meaning chest. So we have air, an accumulation of air inside the pleural space. So previously we were talking about that happening with an open chest injury, but here it's a closed chest injury. And this can occur when someone is maybe taking a full breath and then they get into an accident, boom, they hit their chest on the steering column, and that paper bag effect, because of the opened lung or fully expanded lung, it just gets injured and it can pop. It can pop. And then you also have other individuals that can be victims of spontaneous pneumothorax. So you may get test questions like, and you may see this on your national registry, about like, you have a 22-year-old male that was playing basketball and, reports to you and says that they've been having difficulty breathing for the last 15, 20 minutes. That's just been steadily getting worse. And as you observe the patient, they're a tall, lanky individual. They may have a spontaneous pneumothorax. So this typically occurs in Caucasian individuals that are very tall and very gangly or lanky, and more often than not happens in the like the red-haired, gingered individuals. I don't know why. That's just the demographic that kind of hits hardest with these guys. All right, so open pneumothorax. So we just talked about this. So an open chest wound that allows air to enter the chest wall. So with this, if the hole in the chest wall is greater in size than the patient's trachea, air will enter through that hole, and it creates what's called a sucking chest wound. It's this gurgling, sucking sound. Every time they inhale, yes, air is going in through the trachea as well, but it will also enter in through that hole in their chest. So the very first thing that we do is put a gloved hand over that site, and then an occlusive dressing. An occlusive dressing is anything that air cannot pass through. Here's just an example of an open pneumothorax. So this is where we have the injury in the chest wall, and we have our collapsed lung. All right, so tension pneumothorax. Tension pneumothorax, these are life-threatening injuries. So as air accumulates in that pleural space, there's no way for it to get out because it would normally go back up through the trachea and out our mouths. But here it's stuck. It's trapped in the chest wall. Every time we take a breath, the air will escape out of the lung and just into the chest wall. With nowhere to go, that pressure builds and builds and builds, and then puts additional pressure on top of these other organs. Those other organs being our good lung, our heart, and those great vessels. And as that happens, as the pressure builds up, it's going to affect the patient's blood pressure. It's going to affect their respiratory rate because it's going to become more and more difficult to breathe. And you're going to see signs of JVD, jugular vein distension, and then eventually a late sign is tracheal deviation, which if they already have tracheal deviation, it means that they have been dealing with this for quite some time. All right, here's just another example. All right, so we're talking about pneumothoraxes, that being air, but there's also hemothoraxes. So hemothorax is where blood is filling into this area, and enough blood loss is going to result in shock. That's just obvious. We know that's going to happen. But some different signs and symptoms here is that with a pneumothorax, especially a tension pneumothorax, we're going to get JVD. But with a hemothorax, the jugular veins will be flat. The jugular veins will be flat. That's because the patient is bleeding out. So there's not enough blood for it to accumulate anywhere other than where it should not be, and that is in the chest wall. So we're going to treat this patient like we would any other that is going into shock. Keep them warm, giving them oxygen, and transport rapidly. Here's just a diagram of a hemothorax. So we just have blood compressing the lung. And traumatic asphyxia. So this is where there's a sudden compression of the chest causing rapid increase in the intrathoracic pressure. That means the chest is literally being crushed or squeezed. So again, you might see this in a motor vehicle collision where someone is literally trapped inside the vehicle and their body is just being compressed against the inner compartment. And that traumatic asphyxia, like we see here, it just prevents the lungs from being able to fully expand, and that puts a lot of pressure on everything else inside the chest wall. All right, so continuing on with more specific chest injuries, this is a cardiac contusion. A contusion, again, meaning bruise, cardiac meaning the heart. So this is just some type of blunt force trauma where the heart has now been bruised. So likely the force was enough that the heart is slamming up against the rib cage. Okay, the heart is slamming up against the rib cage. So if you remember back in one of the other, I think it's the overview of trauma, it talks about like the different impacts in motor vehicle collision. So it's like the vehicle strikes the object, you, the passenger, strike something inside, or you're held back by the seatbelt, and then your internal organs slam up against your bones. Okay, so this is where likely to see a cardiac contusion. All right, so we just see a bruising of the heart. So this may lead or may cause what's called a pericardial tamponade. So this is something I want to talk about pretty in depth here. So the pericardial sac, around cardial heart, the pericardial sac, the sac that sits around our heart, can sometimes fill up with blood. Okay, so if one of the blood vessels in the heart is damaged or torn open, it can cause bleeding inside that sac. So every time the heart pumps and beats, blood will just continue to fill up that sac more and more and more. And what happens is that there's no room for the heart to further expand. It can't pump, it can't beat. And so the heart itself is just being crushed to death because it is beating. It's every beat causes blood to escape. That blood gets trapped inside the sac, and it just continues to compress the heart further and further and further. So some signs and symptoms that you see with this are jugular vein distension, okay, because the blood is backing up, all right, narrowing in the pulse pressure. And so if you don't remember what that is every time that you take their blood pressure, the systolic number, the number on top, is getting closer and closer together. So these individuals may or may not, most likely they will have clear breath sounds, unless they have associated injuries of their chest wall or lungs as well. But these individuals, let's say you have a 22-year-old male that was out at a bar and he gets into an altercation and he's stabbed in the left chest, okay, just approximately, a couple of centimeters to the left of or to the right of the heart. Okay, so that may have caused well, actually, let's just say he was stabbed in the heart. All right, so he's stabbed in the heart. The heart, as it bleeds, it fills up that pericardial sac. He ends up getting jugular vein distension. Okay, he ends up having signs of shock. We have that narrowing pulse pressure, but because there's no injury to the lungs themselves, he still has clear and present lung sounds in all four fields. So we might think, oh, he's got JVD, it's a tension pneumothorax, but it's not. It's a pericardial tamponade. So some other signs of this that aren't really talked about here, which are more paramedic level, but even anybody can recognize this, are muffled heart sounds. So if you suspect it to be a pericardial tamponade, obviously treat for shock, rapid transport, but en route, you can listen to lung sounds. All right, my lung sounds are clear. I'm going to listen to the heart, and the heart may sound muffled. Okay, and you might not have a good resonance. You might not be able to hear it very well. That all further leads to the likelihood that you have a pericardial tamponade versus a tension pneumothorax. And here's just a photo showing that we have the sac around the heart, the pericardial sac, is just filled up with fluid. All right, so rib injuries. We talked about these earlier when we talked about a flailed chest. So fractures can cause damage to the lung or intercostal vessels. We know intercostal, meaning in between the costals or in between the ribs. There are blood vessels in between those. It says it's less common in children because their bones are more pliable. So signs and symptoms, you have pain with movement. So every time that they take a breath, it is painful for them. They may be guarding, or they may not want you to touch that area. TTP, tinnitus to palpation, or crepitation. Crepitus being that bone-on-bone grinding. We may see deformities or have just obvious dyspnea or difficulty breathing of these individuals. Coughing or tachypnea, rapid inhalation. So this is probably, like it says here, inability to breathe deep. We're probably going to have rapid and shallow respirations for these guys. Rapid and shallow. An example of a chest injury, scene size up and all this. Okay, we know all that. All right, so checking the MOI, which is one of the first things we do. These are several MOIs that can result in a chest injury. Falls, fights, gunshots, vehicle collisions, like I talked about, crushing injuries, like I said before, being crushed inside the compartment of the vehicle, or possibly an explosion. An explosion, the shrapnel can cause an injury to the chest wall, or like we talked about earlier, where we have a compression injury, and that a blast injury, but it's the shock wave. And this was earlier on in your lectures, where you have the different types of blast injuries. So the shock wave can cause damage to all of our hollow organs, and we know our lung is a hollow organ. Use spinal stabilization if indicated. Okay, so If there's any type of thoracic trauma that is severe enough to break multiple ribs, it's probably a good idea to go ahead and put a C-collar on them just to be sure. But they may not complain of any pain there, but that doesn't always mean that there is nothing wrong. They may just be in greater pain in their chest, and they're just not focusing on what's going on with their neck. Or maybe they're in shock, and they're just not associating any pain whatsoever. So consider CPAP with these individuals unless they have a pneumothorax, because we don't want to increase that intrathoracic pressure any more than we already do, because that's what a CPAP does. It increases the intrathoracic pressure, and that's why we get a drop in blood pressure on our CPAPs. So if they have a pneumothorax, that is air trapped in the chest wall, we don't want to increase that by putting a CPAP on them. Okay, so we're gonna provide positive pressure ventilation if breathing is inadequate. So that means grabbing a BVM and breathing for them. But with a tension pneumothorax, okay, this can result in difficulty when ventilating the patient. So as air builds up in there, it may become more and more difficult to even compress that bag. So we have to look for other signs and symptoms telling us that they are not doing well. We need to look for other signs of hypoxia. Okay, cyanosis being one of those signs. Pallor being the paleness of an individual. So if they are pale, that can indicate hypoxia, poor blood pumping problem, or even blood loss. Could be that hemothorax that we were talking about earlier. Weak rapid pulse can indicate bleeding. All right, so as they are bleeding out, they're trying to maintain their homeostasis. That is, they're trying to get blood and oxygen to every part of the body. So they're trying to perfuse it. So that rapid pulse is going to be an indication of that. All right, like we talked about, assess the neck for any JVD, tracheal deviation, or possibly subcutaneous emphysema. That is air that's trapped in the subcutaneous layer of our skin. And it kind of feels like they have Rice Krispies under their skin. So it's something you can literally see and you can palpate and feel. And always, if there's any possibility of any cervical damage, go ahead and place the C-collar. If you haven't already done so, expose the chest. That should be one of the first things you're going to do. You're going to look at the entirety of the thoracic cavity. That is the front and back, the posterior and anterior. You have to look at both. Any type of open wounds need to be sealed with an occlusive dressing. My rule of thumb, anything above the belly button gets an automatic occlusive dressing. Anything above the belly button. So we know that the diaphragm is what divides our thoracic cavity from our abdominal cavity. And the belly button is just further down than where our, I just said it, diaphragm should be. All right, so again, DCAT BTLS is deformities, looking for any type of deformities in the chest wall, crepitation, like I mentioned earlier, paradoxical motion or movement, like we see in a flailed chest. And we're going to auscultate lung sounds, apex, apex, bass, bass. And it's also a good idea to go ahead and listen on their backs as well. So when you're listening on the posterior portion, make sure that you're not just placing it in the exact same areas. You're going to go in between the shoulder blades, the scapula. You want to go in between, because otherwise the amount of bone right there may make it more difficult to auscultate lung sounds. All right, some other signs and symptoms of chest trauma. Cyanosis, which you know is a bluing of the skin. Dyspnea, difficulty breathing. Tachypnea, rapid breathing. Bradypnea, slow breathing. Hemoptysis, that is coughing up blood. Hemoptysis means coughing up blood. Signs of shock. Oh my gosh. Signs of shock. It's a tongue twister. It's not. English is my first language. I know people are laughing at me. Signs of shock. So, inadequate blood pressure. They are cyanotic or they are pale. They have that pale, cool, clammy skin. All right, we're going to go ahead and treat for shock, keep them warm, give them oxygen, and rapidly transport. And then tracheal deviation, which again, we see only with a tension pneumothorax. You only see tracheal deviation with a tension pneumothorax unless it's some type of severe trauma that has literally shifted the trachea. Those are the only two times you're going to see that. Other times, other signs, paradoxical movement, open wounds, subcutaneous emphysema, which you talked about, JVD, or absent or decreased breath sounds. All right, here's just some other signs you may see. Here's a good one. If every time they breathe in, they have a sudden drop in the blood pressure, okay, that may be an indication that they have some type of pretty severe chest trauma going on. I talked about guarding earlier. This individual is guarding his chest. He doesn't want anybody to touch it. Okay, ABCs, maintain that open airway, reevaluate their breathing, okay, and always check the circulation. Here's 2 rescuers, and this is just a good thing to talk about here at this point because you can see this photo. If you have enough rescuers at hand, you have 2 people ventilate the patient. One person maintaining the seal in the mask, that CE technique, and the other person actually squeezing the bag. You're going to get much better ventilation out of this. All right, so a lot of this is just kind of repeating itself. But here we may have a impaled object. Okay, we have a puncture. So if we have an impaled object, we're going to stabilize that in place. The only 2 times that you remove an impaled object is 1, if it's in the cheek and it's obstructing the airway. And the second time is if an impaled object is preventing you from performing CPR. So if you are unable to perform CPR because of the impaled object, remove it. So why do we perform CPR? They are not breathing and they have no pulse. So yes, removing the object can be dangerous, but they are already clinically dead and we need to perform CPR. So that is when we can remove it and start doing chest compressions. All right, with any type of open wound, seal it with a gloved hand immediately. Boom, place it on there on the chest wall, and then apply an occlusive dressing. So I can't visualize this for everybody here, but for you. So if you do have that type of injury, a lot of people are going to place the palm on top of the chest wall. Probably not a great idea because now my hand is unusable. But if I place the back of my gloved hand on that hole, then I can still use it to open up packages like the package for the occlusive dressing. This way, I'm screwed. I can't do anything. Palm up, then I can actually tear it. Make sense? A lot of people don't think about that, but that's just something that I've treated a lot of, well, like we see here, I've treated a lot of gunshot wounds, and you only fail one time before you realize, like, I need to be better about this. So how do we treat this? With an occlusive dressing. Here's an example of an occlusive dressing. This is called an Asherman's chest seal. These are terrible. Okay, if these are what's on your truck, they are terrible. There's other brands out there like the Hyphen chest seal. Some of them have a vent, and some of them do not. So that vent, that's what this is supposed to be. That's supposed to be the vent, okay? To allow air to escape when you exhale to prevent a pneumothorax. The problem with the Asherman's chest seal is that the adhesive is crap. It does not work, okay? You have to put these on a patient and then thoroughly tape them down. Thoroughly tape them down to get them to even stick and stay. The Hyphen chest seal, I don't know what the newer ones are like, but the old ones are so incredibly sticky that once you place it on there, it's probably going to require like surgical intervention to get it off. Like, they do not come off, especially when they interact with fluids like sweat or blood. Here's an example of a homemade, I mean, that's not the right answer, but improvised, that's the word I'm using for it, an improvised chest seal. So if your wound, here, this is more than big enough, but let's say that our wound was too large for an Ashman chest seal or a hyphen chest seal. It was too big. And we need to improvise, we need to use something else. So we can use any type of occlusive dressing, anything plastic that air will not pass through, like let's say the IV bags. You can cut those down so that you can have a larger surface area. And then the dressing, that occlusive dressing, needs to expand at least 2 inches beyond the size of the injury. It needs to expand at least 2 inches beyond the size of the injury. And then here, we're going to tape it down on 3 sides. That third side should be the closest to the ground, allowing for blood to leak out and go down into the ground. And hopefully, this should not allow air to enter, but maybe is going to allow for air to escape. So this is what the thought behind it is, that it creates a makeshift flutter valve that whenever you exhale, theoretically air can get out. But the reality is it doesn't work. It does not work. So what do you do if this is your patient? You have this type of dressing on the patient and they are showing signs of a tension pneumothorax. What would you do for them? Yes, you could just you could just lift it up, period. Even if they're not exhaling, you could just lift it up for a few seconds. And it's called burping the wound, and you're allowing air to escape that has entered that chest cavity. So you're allowing the air to escape. You're burping the wound. You need to immediately put it back, though. Okay, you need to immediately put it back because we need that negative pressure system to allow our patient to more easily breathe. All right, don't split the chest wall in any way that interferes with chest movement, like we were talking about earlier with a flailed chest. We don't do that. Consider CPAP, except for tension pneumothoraxes. Okay, and then provide positive pressure ventilation, i.e. through a BVM, if their breathing is inadequate. Something else we can do a sling and swath, okay? And more, maybe stabilize that injury. And constantly reassess our patient. All right, so here we're going to talk about pediatrics real quick. So blunt force trauma in pediatrics often cause that pulmonary contusion, that bruising of the chest wall. Typically, they don't break their ribs, but we see a lot of bruising that can lead to a pneumothorax or a hemothorax or a myocardial injury. That is a injury of the heart. Pericardial, like we talked about the pericardial tamponade, and then rib or great vessel injuries. Some anatomic and physiologic differences. The types of muscle fibers in the diaphragm of infants can cause them to suddenly develop apnea. Okay, that is that they will not stop breathing when the diaphragm becomes fatigued. So what they're saying there is that the patients will compensate for a very long time and then just drop off a cliff, and they will go from they will appear to be compensating very well, but they will go to a sudden respiratory arrest. All right, you may see that barrel-like aspect of the chest wall during inspiration and expiration with pediatric thoracic trauma. And with our pediatrics, they breathe much faster than we do normally. So it may be easier to kind of overlook a chest wall injury because one of the signs that we see in adults is rapid, shallow respirations. So the pediatrics are already going to be breathing very quickly, and it's easier to overlook these things. So multiple rib fractures can indicate severe blunt force trauma, and even though it's not mentioned here, that may be something to keep in the back of your mind about alerting CPS. If the mechanism of injury doesn't match what's going on. If they're involved in a car accident and they have broken ribs, that makes sense. If he says that he, tripped and fell off his bike and he has multiple rib fractures, maybe something to look into. All right, these are all things that we may see in pediatric injuries. Open tension, hemo, contusions, diaphragmatic injuries, and then lastly, commotio cordis. Did they ever talk about commotio cordis in class? So commotio cordis is when there is a sudden blunt force sudden blunt force trauma on the chest at a very specific point in the heart's cardiac cycle, causing it to suddenly stop and go into cardiac arrest. So this sometimes they sneak this into the National Registry because it's just not a very common term, and it's really like, are people paying attention? Kind of check on learning here. Obviously, control major bleeding, HABCs. All right, suctioning may be necessary for these individuals, and really that's kind of it with the rest of this. When we talk about geriatric trauma, it's basically the exact same with adults, except that they are more frail, and it is easier for them to develop these injuries like a pulmonary contusion or even a pericardial tamponade. All right, so that's going to conclude this one, and then we're going to move on to the next lecture.